Hello, everyone. So I'm back to finish the anticoagulants, antithrombotics, so forth and so on. And I think we left off right before warfarin or Coumadin, oral anticoagulant. We used to do heparin in the hospital IV and then Coumadin at home orally. It's an old drug. We don't use it as much. Now, more than this one, we use Xarelto. But some doctors still use it, so we're going to talk about it. It inhibits the synthesis of clotting factors, including factor X, A, and thrombin. Oldest oral anticoagulant, used to be the only one. The antagonist is vitamin K, so this is the antidote for warfarin. Blocks the biosynthesis of factors 7, 9, and 10, and prothrombin. And all of these factors are vitamin K dependent clotting factors, so you can see why it's the antagonist or antidote would be vitamin K. Therapeutic uses, long-term preventative treatment of thrombosis, prevention of venous thrombosis and associated pulmonary embolism, prevention of thromboembolism in patients with prosthetic heart valves, and prevention of thrombosis during atrial fibrillation. And we know with atrial fibrillation is the atria is fibrillating a little bit. It's just not quite closing and opening like it's supposed to. It can throw tiny clots all over the body with this arrhythmia. And so a lot of those folks were put on Coumadin back in the day. It carries a significant risk of hemorrhage. Peak effects take several days to develop, and it has a very long half-life, 1.5 to 2 days, which is very long when you've decided to stop a oral anticoagulant, especially if they are bleeding. So again, it's not the one that they use a lot anymore. Again, here, I think I have that in the next slide. No, it's back on this one. The biggest adverse effect is going to be bleeding, and we would look for low blood pressure, increased heart rate, bruises, petechiae, hematomas, again, red-black stools, depending on where it's bleeding in the gut. Red is usually higher in the gut. Black is in the lower gut for bleeding stools. Cloudy or discolored urine. Pelvic pain, headache, and lumbar pain. And some adverse effects of Coumadin. And then we have our newer one, Xarelto, or rivaroxaban, oral anticoagulant. Xarelto is much newer where Coumadin is old. It's more selective inhibition of factor XA, activated factor X, inhibits the production of thrombin. Rapid onset, whereas Coumadin is much slower. Fixed dose, lower bleeding risk, few drug interactions, and no need for the INR testing that we have to do with Coumadin. Does not have an antidote. It's much safer. Poses much less serious bleeds than Coumadin. We use it to prevent DVTs or pulmonary embolus following total hip or knee replacement surgery, prevention of stroke in atrial fib, treatment of DVT and pulmonary embolus unrelated to orthopedic surgery. Adverse effect is going to be bleeding. Both Coumadin and Xarelto are unsafe for pregnancy. It causes pregnancy-related hemorrhage. So now let's talk about our antiplatelet drugs. And that would be our aspirins that suppress platelet aggregation. So aggregation, all that means is coming together, a group of them. Suppresses thrombus formation in arteries, inhibition of cyclooxygenase, which is an enzyme required by platelets to synthesize TXA2. This promotes platelet activation. So again, this enzyme is required by platelets to synthesize factors that promote platelet activation. And again, it's aspirin is to suppress thrombus formation in arteries, not veins. Adverse effect, just like all the rest of them, increased risk of bleeding. Used for prophylaxis of ischemic stroke. TIAs, which transient ischemic attack means you might have a little clot somewhere. Chronic stable angina, unstable angina. Coronary stenting, so it prevents reocclusion of that stent that's placed in there. Acute MI, previous MI, and primary prevention of an MI. It's a myocardial infarction or a heart attack. And then we've got clopidogrel or gliclid, to prevent a stroke. It inhibits ADP-mediated aggregation. Adverse effect, again, hematologic effects, which would be bleeding. And then Plavix is well tolerated, prevents stenosis of coronary stents, secondary prevention of MI, ischemic stroke. And this one is an ADP receptor antagonist, much like aspirin. It resembles that in what it does. Plavix prevents stenosis of coronary stents and used for secondary prevention of MI, ischemic strokes. It blocks ADP receptors on platelets, preventing ADP-stimulated platelet aggregation. So again, Plavix is much like aspirin in that it blocks ADP receptors on platelets, preventing ADP-stimulated platelet aggregation. And aspirin inhibits the enzyme that's required to synthesize platelet aggregation. So they're a lot alike that way, and that's why these drugs are called antiplatelet drugs. And then the last group is glycoprotein receptor antagonist. It causes reversible blockade of platelets. And it's called GPIB3Is. They're receptors inhibiting the final step in aggregation. You don't need to know what they are. So it causes a reversible blockade of platelet, and the receptors inhibiting, it inhibits the receptors, which is the final step in aggregation. And that's what glycoprotein receptor antagonists, just like what it says. They're called super aspirins, administered IV with low doses of aspirin and heparin, most effective antiplatelet drugs. The most common is integralin. It's used for acute coronary syndrome, which we will cover in theory if we haven't already. And again, just as a reminder, aspirin prevents blood clots in the arterial system. Blood clot begins with the platelet plug, which is then reinforced with fibrin. Heparin, as a review, prevents venous blood clots. Anticoagulants, heparin and warfarin, are in the venous system. Aspirin is in the arterial system. And then we'll end with our thrombolytic drugs. And these drugs are very powerful. Streptokinase or streptase is the oldest and first blood clot dissolving agent. So everything else we've talked about has pretty much tried to prevent this stuff. This one, we know the thrombus is there, but now we're going to go bust it up. So these are very powerful drugs. Lytic, remember, means break. So these are the drugs that we're going to break up the clot with. It binds to plasminogen. Its use in acute coronary thrombosis, used for acute MI or ischemic stroke, deep vein thrombosis, massive pulmonary emboli. Adverse effects, of course, number one is always going to be bleeding with all of these. Intracranial hemorrhage, though, is a great risk, and this is the only one for that. Antibody production, hypotension, fever. And then the second one is the newer one. This one's only been out for, I want to say, well, it's longer than 10 years now, maybe 20. It's called TPA. It's tissue plasminogen activator. It's identical to naturally occurring human TPA. It's used in hospitals that are only stroke certified and specially trained individuals for stroke clients. Ischemic strokes only, because we're breaking up a clot. We cannot use this for hemorrhagic strokes in the brain. And it usually has to be within 4 or 5 hours and a witness stroke to do this, because we can cause all kinds of hemorrhage in, as you can see, in stopping this. So how does it work? It binds with plasminogen to form an active complex. The alteplase plasminogen complex catalyzes the conversion of other plasminogen molecules into plasmin, an enzyme that digests the fibrin and meshwork of clots. So it basically does not allow the clots to exist anymore. Therapeutic uses are acute MI, acute ischemic CVA, and acute massive PE. Wait, I'm going to have to fix that. That looks like an error there. So again, what do thrombolytics do? These drugs break down the existing clot, and TPA needs to be given within 4 to 5 hours of having a stroke, pulmonary embolus, or heart attack. If broken off of the body wall, the clot may become a thrombolytic embolism or a floating missile. So we have to be very, very careful with this. And a lot of times, if you're in a hospital that's stroke certified, you will hear things like a stroke team to the ER. This is what they're going to give. They're specially trained in giving this highly selective thrombolytic drug, is TPA. And the nursing responsibilities, as you can guess, with thrombolytic medications or any anticoagulants, lab values must be checked if we're looking for the prothrombin time or the partial prothrombin time. If on heparin or Coumadin, we need to lab match to scales or orders. Patient shows no signs of bleeding in the mouth, urine, rectum, skin sites, or any tubes coming from the patient or client, meaning are they bleeding around an IV site because it's an opening into a vein? Are they bleeding into a Foley catheter? Are they bleeding into a colostomy bag? Any kind of drainage bag anywhere? Are we seeing frank blood? And is the patient on anticoagulants or thrombolytics? Must have accurate calculations. Usually there's a second RN checks prior to giving these medications, especially thrombolytics and heparin. And educate the patients on all of the places where they can bleed. Educate them if they do need to come back for a PTT or PTT lab draw. It's very, very important so they don't start bleeding. So we need to educate a lot with this group of drugs. Okay, that concludes the anticoagulant, antiplatelet, and thrombolytic drug section for our cardiovascular module. I will see you in class.